Stevens-Johnson syndrome. What are they asking about it? Only the treatment. And for how many marks are they asking this treatment? For 3 marks. Okay. For 3 marks, they have asked Stevens-Johnson syndrome treatment. So to write the treatment, first of all, let us understand what it is. Okay, in exam directly you can write treatment, but Stevens-Johnson syndrome basically, let us say a patient came, okay, and then you were doing some treatment for that patient, and then you notice that after she started the treatment, she's getting these mucocutaneous ulcers. Mucocutaneous ulcers. Okay, then you should understand that, okay, she's having a reaction to the drug. Okay, so that is a type 4 hypersensitivity. Type 4 hypersensitivity reaction mediated by T cells. Okay, Stevens-Johnson syndrome is a type 4 hypersensitivity reaction mediated by T cells. It will affect mostly the trunk. Mucocutaneous ulcers will be there. Example, oral ulcers. The amount of skin detachment involved is less than 10% body surface area, because if it is greater than 30%, then you will call it as TEN, that is toxic epidermal necrolysis, which could be life threatening. So you should make sure that this doesn't progress to that. Are you there with me, guys? So what are we looking at? Stevens-Johnson syndrome. First of all, we are understanding it, then only we can write the treatment, correct? Okay, so what is that? Mucocutaneous ulcers, very important. Mucocutaneous ulcers. Okay, involves 2 or more mucous membranes. 2 or more mucous membranes can be involved, like around, they showed the oral cavity, then they showed the eyes also, right? So then it is Stevens-Johnson syndrome, and less than 10% body surface area. Okay, then only we are saying Stevens-Johnson syndrome. But it can progress and it can become toxic epidermal necrolysis, etc., and it may be life threatening, so you should treat properly. That's why in this they are asking you what? The treatment. What are the drugs that they cause, or which cause this? Mostly these are systemic drugs, that is orally if they have taken. Okay, oral drugs mostly that they are saying. Sulfonamides, example, you should know furosemide, hydrochlorothiazide, cotrimoxazole, that is a combination of sulfamethoxazole and trimethoprim, right? So you know these are all sulfonamides. Okay, then NNRTI, that is non-nucleoside reverse transcriptase inhibitor, that is an antiretroviral drug, that is to treat HIV, etc. Then those can cause this kind of reaction, so you should be aware. And then anticonvulsants, if you are giving, like carbamazepine, lamotrigine, clobazam, then vigabatrin, etc. So if you're giving any anticonvulsants, that is for seizure medication also, Stevens-Johnson syndrome can happen, guys. Then you should know about allopurinol, which is used to treat gout. Especially some people who have that particular gene, they can be very sensitive to this, and it can become Stevens-Johnson syndrome in them. So they are recommending that before you give allopurinol, you do a test and give. Okay, or you be very aware of the side effects, ADRs of allopurinol. Then NSAIDs, that is non-steroidal anti-inflammatory drugs, that is painkillers, could be any painkiller. They did not specify the name here. Okay, even this NNRTI names have not been specified. Okay, so these are the types of oral drugs that can cause Stevens-Johnson syndrome, but it is not limited to this list, guys. Then even some infections can cause Stevens-Johnson syndrome. It's just not the drugs. Don't blame only our medicines. It can also be some Mycoplasma pneumoniae. That's a bacteria, isn't it? And then herpes simplex virus. Okay, virus also, bacteria also, everything they are blaming. Okay, now some people who have this HLA, some B something, these people can be more susceptible to Stevens-Johnson syndrome, they are saying. Okay, did you understand now everything about Stevens-Johnson syndrome? Very good. So this is the patient we already showed you. More than 2 or more mucocutaneous membranes, right? They said mucous membranes. More than 2 or more mucous membranes are affected. Okay. So allopurinol, like we told you, that is used to treat gout, right? In that, if you test for this HLA-B something and then you start allopurinol, it is better. It is recommended, they're saying. Especially for Chinese, Korean, Han, Thai people, as well as black individuals. For these people, they are saying. Okay. So India, we don't need to test, looks like. Okay. So allopurinol can lead to what? Stevens-Johnson syndrome. Okay. Then So there will be no 3-ring targets in Steven Johnson syndrome, because in erythema multiforme or something, there'll be like this 3-ring kind of lesions, but here it is not there. Okay. So did you understand, guys? So in Steven Johnson syndrome also it is targetoid, but that they're saying that the 3-ring thing is not there. Steven Johnson syndrome, and you put that erythema multiform here, and then in that erythema multiform they're saying some 3-ring something like this will be there, but in Steven Johnson syndrome exactly that type won't be there. And then the Steven Johnson syndrome later, whatever, if it progresses, what will you get? Toxic epidermal necrolysis, which is greater than 30% of body surface area skin detachment, and this one they are saying is bad. Okay, even this Steven Johnson syndrome also you should be careful. Okay, so what is the treatment? Now let's come to the treatment, guys. We have come to the treatment. Yeah, smile, all of you smile. Why? Because we have come to the treatment. This is what they've asked for 3 marks, so this is what you have to write. Okay, so you have to stop the offending medication. First of all, you identify the medication and stop it. This is the most important treatment of Steven Johnson syndrome. Okay, then nutritional and fluid support. Yeah, we'll give them nutritional and fluid support. Then some people are telling about corticosteroids, but there's some controversy regarding that, and they should say you should start the steroids before the blister occurs or something. After that, they don't recommend. Okay, then IVIG, that is IV immunoglobulins you have to give. Okay, pay attention, guys. It has resulted in decreased mortality, so mortality can occur. So they're telling you be careful, give IVIG. Okay, immunoglobulins, that is right. Then cyclosporin. What is cyclosporin? What is etanercept? These two are what? Immunosuppressants. Excellent. Let's look at that classification. So here is your cyclosporin, which is a calcineurin inhibitor, and then here you have etanercept, which is a TNF alpha inhibitor. So these two immunosuppressants can be used for the treatment of Steven Johnson syndromes. Cyclosporin, that is calcineurin inhibitor, and etanercept, which is a TNF alpha inhibitor, right? So basically those are what? Those are immunosuppressants. Okay, so that you can use for the treatment of Steven Johnson syndrome. And then if they have ulcers, what will you give? Wound care. Okay, and then you can give any analgesics like opioid analgesics, or even basically they're talking about paracetamol, acetaminophen, or opioid analgesics they are saying. Because why are they not suggesting NSAID, guys? Very good, because NSAID is one of the causes of Steven Johnson syndrome. If this progresses and all that, you have to treat it like burns patient. Okay, because of the body surface area involved, etc. You have to treat it carefully. It can become fatal. Guys, you should also refer the patient for ophthalmology. Okay, because you know mucous membrane, mucocutaneous ulcer, right? So if eye is involved, or if you're suspecting, send it to ophthalmology. Okay.